I'm Peggy Peck, MedPage Today, reporting from Orlando at the American College of Cardiology meeting. We've known for several years that implanting ICDs after myocardial infarction can save lives in some patients, but the timing of that implantation has been a question of controversy. Results today suggest that early implantation, in less than 30 days, may in fact not be the best strategy, as we hear here.
All-cause mortality, including sudden death, is highest very early after myocardial infarction, and this has been confirmed also in very recent big trials, even in population-based trials. On the other hand, guidelines based on randomized trials so far recommend not to implant a cardioverter defibrillator within 40 days after acute myocardial infarction for primary prevention of sudden cardiac death. And this discrepancy, high risk on one hand, not proven therapy on the other hand, has puzzled many investigators so far. And almost parallel to a dynamite study, which was the first in this field, therefore another trial was performed in Europe, and this trial is called Immediate Risk Stratification Improved Survival IRIS trial. And the hypothesis was that these patients after acute MI will show indeed a better survival when treated early with an ICD compared to patients receiving optimal medical therapy alone. Criteria for inclusion were twofold. Criterion 1 was left ventricular ejection fraction below 40% together with a high heart rate on the first available electrocardiogram after MI. And the second criterion for inclusion was the presence of non-sustained ventricular tachycardia, that is a run of at least 3 consecutive premature beats on a Holter ECG recorded day 5 to day 31 after MI. IRIS was a big randomized study, and much emphasis was placed both on optimal acute as well as long-term medical therapy. The endpoint was all-cause mortality. Sudden cardiac death in this trial was defined as a death occurring within minutes after the onset of symptoms, resulted from a documented arrhythmia or was unwitnessed but occurred unexpectedly. And sudden cardiac death in this way defined was clearly reduced by the ICD. But this occurred at the expense of an increase of non-sudden cardiac death. Both the decrease of sudden cardiac death in the ICD group as well as the increase of non-sudden cardiac death was statistically significant. In summary, we have to say that in a carefully selected post-MI study group with only moderately reduced ejection fraction, mean ejection fraction in our trial is 35%, all-cause mortality and sudden cardiac death were nevertheless substantial because of the risk stratification we applied. Total mortality was 22.9% and 11.6% at 3 years, so total mortality and sudden cardiac death. Early initiation of ICD therapy in this group of patients, although they are at high risk of dying, nevertheless did not reduce all-cause mortality. During the first month after myocardial infarction, in an optimally treated high-risk patient population, ICD implantation did not offer a survival benefit.
I'm wondering if you could tell us a little bit more about the non-sudden cardiac deaths.
So the death was cardiac, but it was non-sudden, classified by the adverse committee. And well, there are several possibilities, and the exact mechanism is not determined in such a multi-center trial. What are the possible mechanisms? One possible mechanism is that VT-VF in the early period after acute myocardial infarction is not the cause of sudden death, but is an indicator of patients who die anyway And if they do not die suddenly, which is prevented by the ICD, death just takes another door, and they die probably of pump failure. There are some other possibilities which could contribute to this finding. One other possibility we have to look at is maybe the side effect of defibrillator shocks. So we have to look what is the outcome of patients who received appropriate and inappropriate shocks. We have to look at concomitant therapies. We have to look at the patients crossing over from one arm to the other. So this is the topic of a detailed on-treatment analysis, which I cannot give you now.
So, evidence from the IRIS investigators suggests that current guidelines that recommend delaying implantation for 45 days may in fact be the best advice. In Orlando, at the American College of Cardiology, I'm Peggy Peck, MedPage Today.